Dear ladies and gentlemen, warm welcome from my side. My name is Eckard Hamelmann. I'm a professor for pediatrics in Germany at the University of Bielefeld, and my subspecialty is pediatric allergy and pneumology. This is why I want to talk to you about pediatric asthma, asthma in children and adolescents. Just a short glance for my activities as an advisor and lecturer, but this is not conflicting our presentation today. Why do we believe that allergies and asthma are so important? Because they are very, very prevalent. So at least 25% of all children between 0 and 70 years of age suffer from one kind of an allergic disease, and this is mostly in the pediatric field. Asthma is a type of allergic disease. When you look at children, you have so-called type 2 inflammation that is leading to the allergic diseases. And what does it mean? What type of diseases do we see? We see atopic dermatitis, we see respiratory allergic diseases, rhinosinusitis, we see allergic rhinitis, the hay fever, that is of course most common, and of these patients have many patients also comorbid asthma. And then of course allergic and type 2 asthma, which is the focus of my talk today. And then we have food allergy and eosinophilic esophagitis as more rare disease. But all of these diseases you may summarize as a type 2 inflammation, and the more you have of these diseases, the more comorbidities you have, the more likely it is that your asthma or the asthma of your child is uncontrolled and of the more severe type. So what is the burden of the disease when we talk about asthma? Asthma is often, not always, but often uncontrolled or poorly controlled. The hospitalization rate is very high, way higher than in adults, for example. You have many patients that are afraid of asthma attacks, and the overall anxiety level of patients, of the pediatric patients with asthma, is very high. Then of course you have the socioeconomic burden of the disease. You have very high costs for the treatment of the disease, for medication, for doctors, for hospital admissions and so on. You have quite a bit fatalities that can be completely linked to asthma. This is not the problem in the young age group, but when you have asthma and you have persistent asthma, you will still have asthma when you're getting older, and the disease will get more severe, and this is why you have a lot of fatalities. Asthma is ranked number 2 after COPD in the overall chronic airway disease hit list, so to say. And of course in the pediatric field, COPD is a very rare disease, so we are normally talking about asthma when we talk about obstructive disease. And now this is the last number for today. 230 million people worldwide suffer from asthma. This gives you a bit of an idea why asthma is so important. When we concentrate on pediatric asthma, we see that the loss of control is quite frequently, and that poor pediatric asthma control is significantly linked to the risk to develop asthma attacks, severe asthma exacerbations. And the more severe asthma exacerbations you have, the more your quality of life is reduced, or the quality of life of the pediatric patient, of your child. Asthma attacks are frequent and are normally leading to unscheduled visits in the emergency department or to hospitalization, and are the cause for the intake of oral corticosteroids, which by themselves have quite serious side effects. So this is a problem. And then if you look at the long-term problem of the disease, you see that a loss of lung function early in life and an early decline in the growth of the lung is heavily linked to the development of obstructive diseases. Now I'm talking about chronic obstructive diseases in adulthood. So this is a disease that you translate into the adolescents, and if we cannot manage to get a better control on our pediatric asthma patients, we will earn a lot of problems later. patient group. When we concentrate on our patients themselves, or we see, as I said already, anxiety level is very high. Sleep disturbances is a common problem. 28% of all the patients under 16 years have really significant sleep disturbances, and you see missed school days when you have asthma that is treated with a lot of salbutamol as a rescue medication. So you have a bit of an uncontrolled status. You will miss at least 7 school days a year, and normally you lose 1 school year when you have asthma that is on the more severe side. Formally, we said asthma basically has 2 types, extrinsic and intrinsic asthma. So the idea of what is asthma was very, very vague. Nowadays we know that asthma is not one disease. Asthma is a complex disease, or is a mixture of different diseases. When we talk about pediatric asthma, we know that at least 90% of our patients have the so-called type 2 inflammation asthma, and mostly it is an allergic asthma, so it is linked to some kind of an allergic diseases. As I already said, patients have increased numbers of eosinophils in the blood and in the lung, and they have increased IgE levels. The GINA, the Global Initiative for Asthma, describes the type 2 inflammation as a disease where certain cytokines are increased. So you have biomarkers that you can measure, for example, the FeNO, that is something that we can measure in the asthma clinic in the children to manage to monitor the disease performance, to the disease control, and to see if the treatment, the management that we do is really getting any better. And on the other side, we can use a biomarker like IgE to monitor the allergic disease that is behind the asthma. Why do I say this? Because it is nowadays that we really have a significant change in the way how we can treat asthma, and also in children 6 years and older. Formerly we only could use anti-inflammatory drugs, inhaled corticosteroids. Now, within the last 10 years, there emerged a complete new field for the treatment of asthma. We have biologics that are targeting these different cytokines, or the IgE as an allergic biomarker, the different cytokines, IL-5, IL-4, that are so important for the development of asthma. And therefore we have a chance now to treat asthma in a different way. We can treat it more in the endotype specific way. What is the type of inflammation in your child's asthma? How can we treat it when it is getting more severe? And my promise is, looking forward, when we look maybe in 15 or maybe even in 10 years, we will use these biologics way earlier than today to really treat the disease in a more pathophysiology related way, to really hit the cause of the disease. So let me summarize quickly what is the reason why I'm really fascinated about pediatric asthma. It is a common disease, and pediatric asthma can be severe, it can be a persistent problem, and it can remain often uncontrolled, giving us the problems that I told you. Asthma attacks are the frequent cause for hospitalizations, and use a lot of oral corticosteroids with the side effects that are linked to this problem. The currently approved biologics that we have now for our asthma give us hope that we will have a change in the treatment and the management of asthma, and that in the future it is possible to better treat the different phenotypes or endotypes that are underlying the disease development. For the future, for the research, we want to go to. I have linked here some questions. I think one important question is, what are the highest risk patients to develop the persistent type of asthma? to develop the severe type of asthma. How can we choose for this patient group the right biologic? What are the responders? What are the non-responders for the different type of biologic treatments? And then, of course, as a pediatrician, I'm always interested in the prevention of disease rather than in the treatment of a severe disease. I want to really prevent that that asthma develops at all. So what can we do for primary prevention? What can we do for secondary prevention in the very young children? And this is, I think, the biggest unmet need that we need to solve in our future research. And of course, focus on our patients, focus on our unmet needs from the patient and the caregiver's perspective. What do you think is important for asthma? I think we need to listen to our patients and to the caregivers and to see what is important, what is the unmet need, what can we do for improvement in this problem. Thank you very much. Asthma in children and adolescents is a very common disease, is a systemic disease, as a type 2 inflammatory disease. Poor control is pretty common in our pediatric asthma patients and drives the asthma attacks. Serious impact on the burden of the disease and the quality of life is linked to these frequent asthma attacks and exacerbations. And I believe that the new way to treat asthma, the biologics, is giving us hope for the future. Thank you very much.